Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Cherokee Health Systems for hosting today's session, Sepsis in the Ambulatory Care Clinic with Dr. Saadia Griffith-Howard. Dr. Griffith-Howard is an infectious disease physician who has over 30 years of experience providing direct patient care in the ambulatory and inpatient setting. She's participated in infection control and pharmacy and therapeutic committees, as well as the emergency and disaster management planning related to organizational response to anthrax and COVID-19. And we are just so very lucky to have her as one of our MAVEN Project volunteers. So Dr. Griffith-Howard, when you're ready, please begin.
Sure. And Kristen, I don't really have a clock in front of me. So if I start to get close to time, let me know. Okay.
I'll give you a
Thank
20-minute warning.
Okay. Sounds like a plan. Thank you so much. So good afternoon. At least that's where I am. It's good afternoon. And thank you for joining this talk about sepsis and the ambulatory care clinic. Let me see. And of course, I'm having trouble advancing my slides, Kristen.
Go to the
Let me see.
bottom left corner of the slide deck and click there.
Uh-huh.
Uh-oh. Okay. I sound like a
Just,
phone.
yeah.
Can you hit the escape button real quick on your keyboard?
Yeah. Yeah, I'm totally locked up. Hold on. Okay, we're moving. All right. So we're going to start again, and sorry for the technical difficulties. So we're talking about sepsis and the ambulatory care clinic. Today again being December 12th, 2024. I'm going to go through these two screens as to tell you I have nothing to disclose. And as Kristen has already talked to you about the CME credits that are involved with it. So today we're going to talk about several things. We're going to learn the definition of sepsis and the illnesses on the sepsis continuum. I'm going to share two screening tools to hopefully help you in the clinic to diagnose or recognize early sepsis, possible early sepsis. We'll talk about the signs and symptoms of early sepsis, understand the responsibility of the clinic in regards to management of this entity, and hopefully be able to name the type of infections commonly associated with sepsis. I do want to thank Dr. Carter for sharing a little information about your clinic. So I hope that this presentation, although I'll talk about a few things that are not directly applicable to your clinic situation, but I'm hoping that you're going to find that the presentation will be helpful to you. So we're going to start off actually with a case. And as Kristen said, my background is, of course, in infectious diseases, but in my last position, I also was involved with risk management as well as patient safety. And these issues of recognizing sepsis sort of covers all of these. So I've put together a case which is sort of based on my experience, not only as an infectious disease doctor, but also as my patient safety and my risk management hat on. So we'll probably talk a little bit about those two today. So in this situation, we're going to have a 66-year-old African-American male presenting to the clinic with complaints of pain and urinary frequency. He was seen last week by his PCP, who is on vacation this week. So, of course, I know that you guys experienced that. At that time that he was seen last week, he's diagnosed with a urinary tract infection and he was prescribed Bactrim. However, he did not pick up his prescription until 72 hours ago, and he vomited up his last dose of this medication. His wife brought him in and is in the waiting room. She's not in the room with him, but that she reported to the nursing staff that she's concerned because he seems to be confused at times. As you can see, he's not allergic to anything. He's on the usual medications that somebody with diabetes might be on. Hypertension, diabetes, and obesity is his past medical history. And his past surgical history is he had a splenectomy 20 years ago after a motor vehicle accident. I'm sorry. So we don't really have time to do a true back and forth. So what I'm going to do is just point out a few things in this history that we'll touch on as we go through the presentation and hopefully are flagging to you as a red flag. So first of all, he's a 66-year-old man. He is African American, and we'll talk about that as we go. His PCP is on vacation, always a problem because you're lost, you have potential loss of continuity, and it's a patient you really don't know. You know he has a UTI. Does he really have a UTI by his cultures, and is it really sensitive to Bactrim? He didn't pick up the medication, so even if it's sensitive, he really may not have been treating the infection. I like to look at his wife as a gift because she's able to give you some insight into his mental status. His past medical history of diabetes is concerning for risk for infection. And of course, the big red flag in this case is his splenectomy, which makes him an immunocompromised host. So let's keep that in mind as we go through our discussion today. So let's talk. Of course, you can't start without some statistics. But before I focus on the United States statistics, let's just talk globally for a second. That in 2017, there were 11 million deaths from sepsis worldwide. And there is definitely a difference in the incidence and the outcome depending on where you live in the world and your age. 85% of cases of sepsis worldwide come from low and middle income countries, and especially areas where there is social vulnerability, as we're seeing in the world. And when you just look globally, sub Saharan Africa overall has 40% of the sepsis cases worldwide annually. Now, when we come and look here at the United States specifically, we see that each year we have 1.7 million adults in America who develop sepsis, and about 350,000, I figure that's about 1/6 of the patients who develop sepsis here in the US die during their hospitalization or are discharged to hospice. So 1 in 3 people in the United States who die in a hospital have had sepsis during their hospitalization. The two things that I've highlighted in red apply to the clinic. Most cases of sepsis start before a patient goes to the hospital. So that implies that we have a chance to maybe make a diagnosis and impact somebody's outcome. And especially nearly a quarter to a third of people with sepsis had a healthcare visit in the week before they were hospitalized. So again, that suggests that we can make a difference in this illness. And most people who develop sepsis have at least one underlying medical condition, such as chronic lung disease or a weakened immune system. So again, that's something that we should think about. So now let's talk about the definition of sepsis. So we know that we have several definitions from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, which I'll refer to as SCCM and USICM later on in our presentation. But when they look at their definition, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection, as evidenced by organ dysfunction and infection. I do like the CDC plain language kind of description, which basically says sepsis is the body's extreme response to an infection. It is a life-threatening medical emergency. Sepsis happens when an infection you already have triggers a chain reaction throughout your body. So it is a syndrome, and it exists on a continuum, and it is characterized by physiologic, biologic, and biochemical abnormalities, which are basically caused by a dysregulated host response to infection. So the issues that happen in sepsis, if it's in a localized area in your body, not a problem, and actually can be helpful in containing an infection. But when it spreads and becomes a bigger issue, that's when we have our issues with sepsis. So now, as I said, sepsis exists on a continuum. And when you start to look at all of this literature, there are all these definitions: SIRS, sepsis, severe sepsis, septic shock, multi-organ dysfunction syndrome, etc. So I've characterized these in two columns for you. We have the definitions that the Centers for Medicare and Medicaid Services recognizes and still use, which are SIRS, sepsis, and severe sepsis. And we'll talk about those definitions in a second. But more recently, as I said, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, who are our big organizations that deal with this, have reclassified our definitions along the sepsis continuum as early sepsis, sepsis, septic shock, and multiple organ dysfunction syndrome. And we're going to talk about these again. The two things that you see listed here, NEWS and QSOFA under early sepsis, are systems that we can use are scoring systems that we can use to possibly help us identify early sepsis so that we can take action. This is not a slide that you have to memorize, but it's just something that hopefully as we go through these definitions will be helpful to you. So let's talk about definitions a little bit more in detail. So the first definition, which some of us may be familiar with, but which has sort of fallen out of favor, is the systemic inflammatory response syndrome, also known as SIRS. And this is a clinical syndrome that is a form of dysregulated inflammation. And it's defined as two or more abnormalities in temperature, heart, respiration, or white blood cell count. So that's what SIRS was involved. Now, SIRS has sort of fallen out of favor and is not used as much because it can also apply to things that are not infectious. So if you think of a patient perhaps with severe pancreatitis, they can have elevation of their temperature, heart rate, respiration, etc. They can have abnormalities there, and that has nothing to do with infection at all. So because of that, SIRS has sort of fallen out of favor. It's not used very much. Although I think still, if you see these abnormalities, you know you're having a dysregulated form of inflammation, and it should make you think that this is a patient who is seriously ill and perhaps does have an infection. Early sepsis, which is a definition both under the CMS as well as the other organizations, has really no specific definition. So it's before sepsis. Maybe you had a chance to do something, but there's no specific definition for that. So then we get into septic shock, which includes also severe sepsis. So the concept of severe sepsis is included in septic shock. And this is sepsis that has now developed a circulatory, a cellular, or metabolic abnormalities that are associated with a greater risk of mortality. So that's such as the patient who was septic but now has hypotension. They're septic, but now they have an elevated creatinine or evidence of liver failure. So that's what we mean when we start to talk about septic shock. And then finally, you have the concept of multiple organ dysfunction syndrome, which is basically the last stop on this continuum before you would have death, where you have progressive organ dysfunction in an acutely ill patient, such that homeostasis cannot be maintained without aggressive intervention. So as I said, is it sort of the severe end of that illness spectrum from both infectious and non-infectious conditions. So they talk about MOD as being primary or secondary. And certainly secondary MODs can be a result of having sepsis, bacterial, fungal, viral, etc. So again, a lot of terms along this continuum. As a clinic, you're basically involved with recognition of early sepsis. Perhaps if you still want to keep the concept of SIRS in your mind, that's fine. But usually when patients have sepsis, septic shock, MODs, those are very sick patients, and those are patients that are in the ICU. So now I have a continuum, and just to go a little bit into the pathophysiology of sepsis, I have this graphic for you. This is from airinspiredpencil.com. Most of my other graphics, if you are interested in them, are from the CDC and the Surviving Sepsis campaign. But I just captured this graphic for you just to really highlight the fact that it's complicated. The pathophysiology of sepsis involves the release of pro-inflammatory mediators to an infection which exceeds the local boundaries and leads to a generalized response. So it escapes the local area. Maybe it was a UTI, an infection in the kidney, where those responses would be appropriate, but now it's escaped and it's become generalized. And the cause for sepsis is multifactorial. It has to do with the microorganisms, which can be bacterial often and most commonly, but it can also be fungal, it can also be viral, it can also be parasitic, depending on where you live in the world. And it can be the reaction of the body to those microorganisms, but also toxins that those microorganisms may make, or characteristics of cell walls, et cetera, that activate the system. It also involves complement activation, and it involves the release of large amounts of pro-inflammatory mediators. So again, you can see it is a complicated situation with feedback loops that in normal situations would control the amount of inflammation. But in this situation, when we really get into a septic syndrome, things are basically out of control. And one short sentence that I read said, just picture uncontrolled intravascular inflammation. So that definitely that should give you an idea that there is a lot going on. So now let's get into the ambulatory care clinic's role in sepsis. And on the right side, you'll see a little graphic from the CDC. So the CDC has a whole campaign about recognizing sepsis early, get ahead of sepsis, which is something that you can certainly examine on your own in terms of graphics and educational material for your team. But in an ambulatory care clinic's role in sepsis management, I think is this early recognition of possible sepsis and its precursor states. Hopefully, you are making a diagnosis in a precursor state situation. As we said, again, many patients have come to the office the week before. Timely transportation to a higher level of care. I put that in red, usually an emergency room. And then in the regular clinic, I think follow-up care and patient in education, which I've put in blue, is very, very important. In black, we still have some things, IV fluids, baseline labs, source control. Depending on what kind of a clinic that you're in, you may be able to impact some of those things. Where I did my last work, we did have an urgent care on site. So, and we did have labs available that we could get stat. So some of those things we could do. But I think for the average clinic where you don't really have stat labs and you have limited antibiotics, et cetera, you're in the blue zone and the red zone. Early recognition, getting them to a higher level of care, which is usually an emergency room, and then follow-up care and patient information and education, excuse me, which are also very important. So what are our risk factors for sepsis in the United States? First of all, who should we be concerned about? Somebody who was in the intensive care unit in the past or is in the intensive care unit now because of an infection. Those people are at risk for going on to develop full-blown sepsis. If you have bacteremia, and even though I said bacteremia, remember candidemia, fungal infections, etc., are putting you at risk. So that's a risk factor for developing sepsis. What is your age? In the United States, we talk about age greater than 65 being a risk factor for sepsis. But when we look worldwide, actually the incidence is highest in children less than 5 years of age. And then it starts to take off again at the age of 60 if we're talking globally. Of 11 million sepsis deaths that occurred worldwide in 2017, 26% of them were under the age of 5. So again, I'm not really discussing pediatrics in this presentation. I'm not a pediatric infectious disease doctor, but again, I would certainly say your children less than 5 should have your antenna up, but especially our older patients are going to be of concern. Does your patient have immunosuppression? It can be from their rheumatologic illness, it can be from their underlying cancers, those kinds of things. It could be, as in our case, that the person had a splenectomy many, many years ago. So we know that immunosuppression is a problem, and as our treatment for illnesses continues to cause immunosuppression, it's something that we want to worry about. Diabetes and obesity are a risk factor. Cancer, it can be from the cancer directly itself. Suppose somebody has a hematologic cancer, which would affect their white blood cell counts, etc., or it can be from chemotherapy. Community acquired pneumonia is a risk factor for sepsis. Previous hospitalizations, which can just be a marker of a very sick patient, of course, or things that we have done. I have seen people who had IVs in, developed an occult bacteremia from a previous hospitalization that was not picked up. So somebody who was previous hospitalized should have your antenna up for sepsis. And of course, genetic factors. As I said, we're not sure why, but certainly there does seem to be an increase of sepsis in the African American community, especially African American males. Whether this is socioeconomic or bias, we're not sure at this point, but something that you should always be thinking about. So several risk factors for sepsis have been identified here in the United States. So what are the signs that we might see in the clinic? Arterial hypotension, and we're going to talk about what is hypotension for an individual patient. You can have a temp over 38.3 or under 36C, and I went ahead and because I can never remember. So if we talk about Fahrenheit, that's a temperature over 100.9 Fahrenheit or below 96.8. A heart rate of over 90 or more than 2 standard deviations for their age norm. And remember, if we have people on beta blockers, they may not show us that tachycardia that we're used to seeing. It really is amazing when you see a young person who we are so used to seeing older patients, but when you see a young person who can really mount a heart rate of 120, 130 just in response to a temperature infection, it's not something that we see that often. A respiratory rate over 20 breaths per minute certainly could be a sign of sepsis. And the signs of localized infection. Remember, do they have the signs of pneumonia, UTI? Do they have a skin infection? That should also make you think, hey, this is a patient who may go on to develop sepsis. And hopefully something that you're not seeing in the clinic situation, but certainly signs of end organ perfusion abnormalities is a very bad sign. Warm, flushed skin or cool cyanotic skin or modeling, if you've ever seen that, which is very impressive and concerning. Or you can have people who have anuria, oliguria, mental status change, which suggests that there may be a perfusion problem or it could be a metabolic problem. You can have ileus or absent bowel sounds. So again, there are signs, but these are all nonspecific. Again, but it should put our antenna up. So now we're in a busy clinic. We're going through the day. Is there anything that can help us to identify some early signs of sepsis? And there are two scoring systems that have been developed, one that can help in this regard. And one is the NEWS National Early Warning Score for early sepsis. This is the score that's most preferred nowadays among physicians. Remember, I said we were going to talk again about the two organizations, the European and the American Critical Care societies. And it is a scoring system that gives you a score of between 0 and 3 based on respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion or temperature. And you don't have to remember all of these. There are online calculators, and in my references, I've included a link to the online calculator for the news score. And this score will represent the risk of death from sepsis for a patient, but it also indicates the urgency of the medical response. So if you have a score of 0 to 4, that's considered to be low risk, and somebody who you may be able to treat on the medical ward. If you have a score of 5 to 6, it's a medium risk, and they're the threshold to an urgent response, which would be more ICU based and more aggressive. And a score of 7 or more means that you're high risk for death from sepsis, and you would use that patient would require or deserve an urgent or emergency response. So, not to give it away, our patient, as we look at the news score, as we're going to go through with more information for them, would come to a medium risk for sepsis. So that's one scoring system that can be used. Whether all of those are available, a lot of those are bedside, but whether you have the ability to do oxygen saturation in your clinic, we're not sure. So let's look at a even simpler score to identify early sepsis. And this is the Q-SOFA score, Quick Sequential Organ Failure Assessment Score, Q-SOFA. And this is a modified score of a longer score that's called the Sequential Organ Failure Assessment Score, or the SOFA score. And that includes many of the things that we talked about on the news score on the previous slide, with a few extra things thrown in. But the Q-SOFA score is easily identifiable at the bedside. And that would involve a respiratory rate greater than or equal to 22 breaths per minute, any type of altered mentation, and a systolic blood pressure less than or equal to 100 milligrams. And you'd get 1 point for each. And if you have a score equal to or greater than 2, so which would be 3, that's associated with a poor sepsis outcome. Now, the Q-SOFA score has been again endorsed by the same two medical groups, and it has really been studied in the emergency department. So it's really a little bit more focused on identifying early sepsis. It still needs to be validated. The Q-SOFA, the shorter score here, as opposed to the SOFA, has to be validated in an ICU setting in terms of prediction for bad outcomes. But in the ED, it has been shown to be helpful to identify patients at risk for sepsis or who may be experiencing early sepsis. So if I had to focus on one of the two scores, I would focus on the Q-SOFA score for the clinic situation. Now, let me put on my risk management hat for just a second and talk about the electronic medical record and sepsis recognition. So the good thing about the electronic medical record is that you have a wealth of information at your fingertips. The bad thing about the electronic medical record is you have a wealth of information at your fingertips. And on any given day or in any clinical situation, the question is, how much do you review? How much are you required to really look at when we start to talk about things from a risk management point of view? But the good news is, if you're covering for your colleague and they're not here, you do have a patient's past medical history and past surgical history available. In our case, the fact that this patient doesn't have a spleen is very important. You also have ability to review what their normal vital signs are. So even though a set of vital signs may not look unusual on any given day, when you take a quick peek back in the history and you see somebody usually has a higher blood pressure, or they usually have a slower heart rate, something that may be striking you as being in the normal range may suddenly be something that's not so much in the normal range. And the third thing about the electronic medical record is there have been several studies and tools developed that use artificial intelligence and alert systems to alert clinicians to the risk of sepsis, and also present treatment protocols for them. So you may have a situation where the EMR is able to look and say, this patient fits 2 criteria for sepsis, or 2 criteria for the Q-SOFA score, or 2 criteria for SIRS. do you want to take action, physician or healthcare provider? So they've done some studies around this. And some of the issues with these kind of systems is that they do not always pan out. So in one study, only 38% of the alerts that the teams received because of possible early sepsis or SIRS were confirmed by the team. So that means the majority of the time, even though you got this alert, when you looked at the patient in detail, they didn't have any kind of sepsis or sepsis risk. But another meta-analysis of 22 studies addressing ED departments who were using some sort of alert system were associated with reduced mortality and a shorter time to IV fluids, blood cultures, and antibiotic administration. So I think the final decision is out on these systems, but I think they're good in the sense that they can help us to avoid diagnostic bias. And so I don't know if your electronic medical record has one of these available, but again, I would think I would look at it as a gift if you are asked that question because it does allow you to think. So again, staying in the risk management sphere and also staying in my patient safety sphere, I've asked you to think about, is your team empowered? Because we know that we are human and we will make mistakes and we can miss sepsis. And the reality of the situation, at least when I was doing clinical medicine, and I'm sure it is for you, you're in the middle of a busy day, you're just trying to, you want to see your patients, but we're always at the risk of complacency. We're at a diagnostic bias risk where we're going to look perhaps for the easiest answer. We're going to miss some clues. And how can we minimize that? Well, one way we can do that is to really have a team approach and a team approach to recognizing these patients. So I've asked some questions and the answer is not here, but you guys can think about it. So remember, we're always at risk for diagnostic bias. We as humans, we tend to look for the common diagnosis. The patient that I created for us, we know he has a urinary tract, we suspect he has a urinary tract infection. He didn't take his medicine. Maybe we're not going to think any further than that, but we certainly should. Um, is your team educated on sepsis recognition and what are your triage protocols? You may or may not be the person to put that patient in the room, but if your nurse or your clinical assistant has also received education, they may say, hey, I'm concerned about the temperature that Mr. So-and-so has, or I've seen him before, he's not acting himself. And for your team to really be able to do that, you have to live in a world of flattened hierarchy. And what do I mean by that? That's one of the worlds where I may be the doctor, but I'm not a know-it-all, and I am approachable, and I can hear your concerns about the patient because of patient safety. And I'm on a team with good communication so that we can talk back and forth. The other thing that I've always enjoyed about working in a clinic situation is that I can bounce cases off of my colleagues. And I think that does a lot in terms also of diagnostic bias. So maybe you're down the hall from another provider to say, hey, I have this patient in here. He has this temp, he has this, he has that. What do you think? Is this somebody you would send to the ER or would you, send him home? So again, these are sort of patient safety, risk management thoughts, but I thought it was good to include them in this talk. So let's get back to our case right now. So observation of the patient reveals him to be uncomfortable, but able to answer questions slowly. He has left-sided pain on his back, which started about 2 days ago, and he feels he's not making as much urine as usual. No other localizing signs for infection are reported. Let's look at his vitals. Temps 96, heart rate 96, respiratory 22, blood pressure 106/84. His mucous members are dry, his skin is warm, he has a glucose of 220, and he really has an unremarkable exam except for some left CVAT. But you take a moment to review his chart, and you see he's never got his pneumococcal immunization. And at his last visit a week ago, his temperature was 130, I'm sorry, his blood pressure was 136 over 92, significantly different than today. His heart rate was 70 at that time. So this heart rate of 96 is significantly increased also. They didn't do respirations last time, and you do see that his urine culture grew E. coli sensitive to Bactrim. So if you use the Q-SOFA score, his score is 2. If you do the news score, I didn't include it on the sign, but the news score would be 5, which says that he's at risk of developing sepsis and is on the threshold of an urgent response. But basically, based on your Q-SOFA score of 2, with his abnormal respirations and his mental status change that you're noticing, and again, thanks to his wife, a call to 911 is placed for urgent transport out of the clinic, which would be the appropriate response for this patient. So timely transport to a higher level of care, I put that in red. On the right, I have just included from the Surviving Sepsis campaign their little graphic of all the things that should happen in the first hour of a response to a possible septic patient. Obviously, more that can happen in your clinic. So that's why it's so important for you to begin steps to transfer your patient to a higher level of care. While you're waiting for this patient to be transferred, I've had the quick transfers, but we've also had the slow transfers. You certainly want to keep an eye on the patient. He shouldn't be in a room where nobody is checking on him. And hopefully you have made time for what we call a warm handoff to your emergency department so that they know about your concerns. They know that this is a patient who doesn't have a spleen. They know about his recent infection. But as you can see, there's a lot of things here in terms of supporting and making a diagnosis that would not necessarily be able to happen in the regular clinic. So where I was before, and depending again, your clinic treatment could include things such as immediately giving supplemental oxygen, if you have the ability to place an IV, giving IV fluids, of course, and getting a line in. Lab studies that we would get for baseline labs, even if they don't come back right away, these are helpful labs that you could have on. And especially cultures, of course, if you can get peripheral blood cultures from 2 different sites, urine cultures, other targeted cultures. And again, I've highlighted frequent observation. Again, this may not be something that can happen in your clinic, and you have done your duty if you're trying to get your patient to the hospital. Source control and possible infection sources, again, a challenge for a clinic environment. But if you have an obviously infected catheter or foreign body that is easily removable and there's going to be a delay in transportation, you can consider removing it. Again, the problem sometimes if you take out a PICC line and the patient has no IV access, that can be a problem. But certainly if you see pus coming out, you can culture around it. I've had the situation where abscesses spontaneously drain when you're examining the patient, and certainly you could at least perform a culture, even if you're not going to do a full I&D. And again, if you have a delay in transport and you have the ability to begin an antibiotic, you can consider that. Guidelines are against immediate administration of steroids, so you don't have to worry about that anymore. That's something that would be more thoughtful and could be done in the emergency room. So common sites of infection in sepsis. This is a confusing slide as I've written it. So let me just say that the way I have things here ordered, they're ordered in terms of mortality first. So if you have sepsis from the GI tract, that's associated with the highest mortality. And the highest mortality is actually from the ischemic bowel, which has a 78% death mortality rate in sepsis. And your lowest area of mortality when you have infections causing sepsis are from urinary tract infections, with the lowest mortality being about 26%. But still, that is about a quarter of the people who have urosepsis can still expire from that. Sepsis due to nosocomial pathogens have a higher mortality. But if we were to reorder this slide in terms of the frequency of infections that cause sepsis, the number one site would be the lung. So 40 to 60% of cases, pulmonary cases, are the site of infection. And then after that, abdominal cases or GI cases are responsible for 15 to 30%. And then GU cases, urinary tracts, are 15 to 30%, followed by bacteremia, skin, etc. So again, the highest mortality is with the GI tract. The lowest mortality is with the urinary tract. But if you had to say, what is the most common site of infection that cause sepsis? Your number one would be pulmonary, and your number two would be abdominal, and your number three would be the urinary tract. Antibiotic choice, of course, in sepsis is based on history, comorbidities, and all the other things that I've listed on the slide. Your decision usually is for a broad spectrum agent with or without vancomycin. Consider fungal agents with certain presentations. The most important thing I think for you in the clinic is this is not a time to be giving oral antibiotics. Antibiotics, when you have somebody you're concerned that may be septic, really should be IV, and they should be adjusted for renal and hepatic dysfunction, but also maximal doses of antibiotics need to be administered. So again, this is not something that commonly happens in the clinic. I understand you have limited antibiotic availability. If you had somebody who was going to be there for a very long time and you could give some IV ceftriaxone, depending on the state, that could be something that you could consider, but certainly tell the warm handoff in your emergency room that you did that. But again, in the clinic, your focus is really to getting them there. But I didn't want you to feel that, oh, let me get in an oral dose of some medication just to help along the way. You try to avoid that. So let's talk about our patient again. The patient returns to your clinic for follow-up care post-hospitalization. So he was hospitalized. When the patient got to the ER, they found that his white count was 23,000. He had all the hallmarks, the elevated lactic acid level. His bilirubin was up, signifying liver problems. His creatinine was up, signifying renal problems. His glucose was up, and we know hyperglycemia makes the treatment of infection more difficult. He was admitted to the medical observation unit and treated with IV antibiotics, IV fluids, and supplemental oxygen, remembering that his news score said that he was on the way to being an urgent response, but you got there in time. The surprising thing for this patient, although not surprising when we remind ourselves that he didn't have a spleen, he had 2 sets of blood cultures that were positive for strep pneumo, and no source was identified. Ultrasound did confirm pyelonephritis involving the left kidney in the face of a large kidney stone. So again, with this particular patient, we could have fallen prey to diagnostic bias by just assuming we know what infection he has. He has a urinary tract infection, and Bactrim is not very good for strep pneumo, so we might have missed this infection in the patient. The patient was discharged on IV ceftriaxone via a PICC line and is to follow up with the infectious disease and the urology providers. But when you question your patient, appointments have not been scheduled, which happens a lot in the reality, I'm sure you know from patients leaving the hospital. A lot goes on and the patients miss a lot, and also sometimes it's hard to get appointments. So what's the role of the clinic? Follow-up care and patient education. Sepsis survival carries an increased risk of death. We know that about 20% when the people who have sepsis will die, as well as a sepsis recurrence and hospital readmission. About 10% of the people who survive sepsis have a recurrence. So this patient is now at increased risk of sepsis recurrence, especially with the lack of the spleen and his diabetes and obesity. And actually, the increased risk of death actually is mostly in the first 6 months after a sepsis incident, but the risk remains elevated for 2 years. Questions for you. Did your patient keep their follow-up appointment with you and the specialist? In reality, we often find, as I said, that patients have a lot of information when they get discharged and they miss the important things. So as a clinic provider, you can reinforce that or maybe even assist them in getting the appointments that they need or communicating with the specialist to find out what should happen. Did they complete their antibiotics and have their PICC lines removed? A lot of patients, the transition out of the hospital can be difficult in terms of them getting their IV antibiotics. And again, I've had many experiences where patients disappear with their PICC lines still in, and then that becomes a risk for additional additional bacteremia related to staph. And more important is, do their family members know the signs and the symptoms so that if they have a recurrence or if they start to feel ill, that they know what to do and they're empowered to call you or take the patient to the emergency room for treatment. So with our patient, it's going to be very important for him to see the urologist so that that kidney stone can be dealt with because it may be infected at this point and be a nidus of infection for the future. So as promised, I included in the slide deck 2 calculators links. So easy peasy, you can go to them and you can quickly, if you have a patient and you're concerned, you can do a Q-SOFA score that might help to break you out of some of your diagnostic bias and avoid minimalization. The news calculator is there also, more things to look at, but also would be helpful. I have references here for you. And as I was telling Kristen last week on the December 5th, New England Journal had a whole review of sepsis. So I will update the slides before they're posted to include that reference for you. And it has everything you need to know and more about sepsis. And then I just have a few other references for you, a little bit about the alert systems, if that's something that you are interested in. And I'm going to stop the formal comments here and say thank you and be available for questions.
Thank you.
And again, this is the Get Ahead of Sepsis campaign information here that you're saying. Okay.
Thank you so much, Dr. Griffith-Howard. I am an awful timekeeper because I lost track of time and I did not give you a warning. But
Okay.
thank you so much. This was great. During the pandemic, we heard a lot about, oh goodness, cytokine storm. I warned you about big words.
Cytokine storm. Okay, keep going.
Is this equivalent to sepsis?
Well, yeah, so I would say it's a little bit different than sepsis, but it can have some of the same outcomes on the end organs. There actually has been discussion that COVID-19, yes, COVID-19 itself, the virus can cause sepsis. It can cause dysregulation. So yes, cytokine storms could be a part of the sepsis response and lead to organ dysfunction. It is part of this same issue. But again, a lot of the controversy around at least the initial response to viral infections when they're causing a septic picture is, should you have people on regular antibiotics or not? And certainly once you realize that it's all just COVID-19, then the regular antibiotics aren't needed.
Okay, I stopped share so we can see you.
Sure.
Next question. What about ceftriaxone IM if there's
Ceftriaxone IM, yes, I would not recommend IM ceftriaxone because remember you're having shutdown of your peripheral circulation, and circulation is not helpful. So I would try very much to only deal with IV medications. There are exceptions to every rule. I can say if you really are a situation where the patient is not going to be transported out and you need to give them something, you could give the IV ceftriaxone. You need to communicate that to the team that's receiving them because they would put that in their calculations of how much antibiotics to give them. I sort of glossed over it that when you're with a septic patient, it really is important to give them maximal doses of antibiotics. And a lot of times as an ID doctor, we would come in and we would see that the patients really, for their renal function and their hepatic function and their estimated vascular space, because of the changes, that they really were not getting enough antibiotics. So if you really had a septic person, we know their ceftriaxone can go up to 2 grams, and you gave a gram IM, they could probably give a gram IV, but in general, you really want to stick with IV antibiotics.
Great. What are keynote symptom patients' reports of pyelonephritis? Do they always have dysuria?
Dysuria, say it one more time. What are
The keynote
dys
symptoms patients
oh,
report
is it
of.
with pyelonephritis? Okay, do they always have dysuria? No, pyelonephritis, they may not always have dysuria. Certainly, you're thinking about that when you have the cerebral CVAT, cervical, I'm blanking on CVAT, but when you have the CVAT tenderness, you definitely think about pyelo. When you have frequency, sometimes you can have urgency. Most people will have some dysuria, but it's not absolutely necessary.
All right, Dr. Mazzullo, I see your hand is raised. I'm going to unmute you. So Dr. Mazzullo, you can unmute yourself.
That was the wonderful presentation. I'm a displaced New Yorker in Boston, and it's so good to hear you talk. I could just
Uh-huh.
listen to you for hours.
Uh-huh.
I feel like I'm back home. It's, they knock you. I can't say dog anymore up here. I get yelled at. But I don't.
Right. Yeah.
But I used to say cardiac. I had to learn that. I didn't even know what cardiac was when I got here. But anyway, I have to ask a personal question. Kristen knows
Sure.
I'm a renal transplant patient and I get sepsis all the time. And
Okay.
I have a different syndrome that I've never figured out. Know what my first symptom is? And I'd love to hear from you because my doctors are always silent about this. I get rigors that are just terrible and nothing stops them. And I have to plead with my doctors for a Demerol shot because that's the
Yeah.
only thing that really stops the rigors. What's that all about?
Yeah, I think so. I'm happy. So first of all, yes, I'm a New Yorker, and I thought my accent had gone away. So I'm actually happy that you still hear
No,
it, Dr. Mazzullo. So that's
it's
so
so
that's good.
proud.
And I'm glad that one of the things that I had wanted to say, and really which was highlighted in the New England Journal article that I'm going to include, was that another real risk factor for sepsis is uh, renal patients who are on dialysis. And I forgot to really emphasize that. And it's often because of the lines that they may have in to access hemodialysis, but they are also immunosuppressed. So again, your dialysis patients, think about them, sepsis in them. And then getting to you, Dr. Mazzullo, yes, I have seen patients who have rigors as their initial presentation. And it may be that there is some sort of low level bacteremia happening, or some reaction to a part of a bacteria that is getting into the bloodstream and it's causing the rigors. One of my rules is, if my patient knows themselves, and I have a patient who tells me that when I get rigors, this is the sign of sepsis for me, I believe it and I pursue it. And yes, Demerol is very good to treat that. And we have experience, with using Demerol for rigors, especially when we use amphotericin. And we know that they can have a sort of a rigor response to that information. So I think this is the uniqueness of you, and hopefully your doctors have learned that, and obviously you've learned it. And that's the conversation to have. But you may have some sort of uh, toxin, not a toxin, but part of a bacterial wall or something that is getting released into the bloodstream and you're reacting to it.
Yeah, I think you're absolutely right. And
Yeah.
once I had to go to a hospital that didn't know me and they thought I was drug seeking. It
Right,
was an
right.
awful experience.
Yeah, yes, yeah. I'm sorry that you had you experienced that, and in a sense, you are experiencing what so many patients
Right.
experience, right? And at least you're empowered to speak up for yourself. But just imagine those who are not.
Thank you very much. I'm going to have
Hmm.
our clinic we need a lecture to remind us about early sepsis
Yeah.
ourselves.
Mhm.
It's very important. You know, we've never done that, and it's so
Yeah.
important.
Yeah,
Thank
it
you
is.
so
And
much.
yeah, oh, you're welcome. You're welcome. And as I said, the other, excuse me, the other hat that I wore as I was leaving was the whole idea of team training. And I did a lot of work with the ORs and the surgical teams, but you really just applying that to the medical clinics is as important because we need the whole team to respond. And, you know, a good nurse or even a colleague that just sort of says to you, hey, could it be this? And they feel comfortable saying that to you as the physician, right? Okay, you know, do you think the patient could have that? And our ability to listen to that and respond to it will save lives.
Thank you so much.
Mhm.
Both. All right. If there's, can you clarify the recent changes of definitions?
Sure. And I don't want to go back on the slides, but you know, the Centers for Medicaid and CMS, Medicaid and Medicare, they're always I don't want to say behind times. They, you know, they have the reasons that they look at certain definitions. The way I would think about it is sepsis is a continuum. What you really know is that there's early sepsis before the whole syndrome starts, and you start to have the organ dysfunction and you start to have the vascular changes. And we can call it a lot of different things. I don't think it's worth you memorizing everyone. You're really just worried about, is it early? And then understanding that as it develops the organ dysfunction, there are other names for it. Severe sepsis, you know, MOD syndrome, all of those things are basically just trying to say where on this continuum after sepsis develops a particular person may be. And for the average doctor who's not in research, it's really not that important.
Thank you.
Hopefully that helps.
I don't see any more questions, but you know, we'll always pause and make sure you want to get your last minute questions in. While we're pausing, I'm just going to do a quick reminder that we are doing our annual clinic provider survey. So this is your one chance of the year to offer feedback, tell us anything you'd like, talk about how great our ed sessions are, but really just to kind of give us an idea of how to plan for the next year and what would be of most use to you. You should have received an email, but I'm sitting here trying to stall while I get the link to the survey. If you could complete this in addition to your CME survey, that would be fantastic. I swear I know it's somewhere. So I will find that link and I'll post it in the chat, maybe. Or not. We'll just end it because I can't find it. Anyway, we have thank yous and excellent lectures. I agree. Dr. Griffith-Howard, this was fantastic. And thank you all for joining us today.
Thank you. Thank you for joining, and happy holidays.